Hello, my name is Nerly De La Rosa Mercedes, and I will be presenting the article that I read, which is titled, "What Can Patients Tell Us About the Quality and Safety of Hospital Care?" These findings are from a UK multi-center survey study. So this is just a layout of what I'll be speaking about, which are a layout that is very similar to the layout that is spread and displayed in the article. But before I talk about the things that are presented in this layout, I will be speaking on the background and introduction of the study. But first, I want to highlight some key points for the layout that is here written in the table of contents. So before I speak about the background and the introduction, I'm going to explain this layout. So for methods, a key point is that 2,471 patients gathered and 231 reports are processed in a two-stage clinical review. For procedure, a study was conducted with volunteers spending at least 4 hours in the ward. For analysis, data was analyzed in 2 stages. For results, 1 in 10 patients, 264 patients identified a patient safety incident with medication errors. This information is key because it is also discussed in the discussion and also leads to the concluding statement of the study. So for discussion, 65% of patient incident reports would not have been classified as PSI, which just shows how important patient feedback is for the use of PSI. For conclusion, patient feedback is important in order to improve safety and healthcare services. So first of all, what is the background of this article? How did patient feedback come to be the key thing for this article? So the purpose of the study was to determine if the feedback of patients was important to improve the healthcare services and detect the errors that can cause for patients to feel unsafe or neglected. Previously, studies were conducted with just clinical feedback, and so patient safety incidences were just determined by staff and healthcare workers. It is explained in this article that many studies were used with just the staff or the clinical staff who were involved with the services that patient received, and they only provide patient safety with the healthcare workers' feedback, but they never included the patient feedback. And it also explains that those articles previous to this one who did include patient feedback only included a small number of patients. So by far, in that time period that the article was made, that the study was done, that was the largest patient feedback study that was conducted at that time period, which really gives a more magnified result of how essential patient feedback is to improving healthcare services. And how I mentioned before, however, many articles suggest that the use of PSI may not be enough since identifying safety has been difficult due to error detection methods. For introduction, let me introduce what is PSI. What does PSI stand for? PSI stands for Patient Safety Incident. What is it? It is a reporting system that measures and identifies harm, the cost and effectiveness, and supporting organizational learning. PSIs are important in hospitals because they prevent complications in inpatient care when it comes to billing, ICD-9 codes, demographics, length of stay, and other data in each discharge. They're so essential that there's even a progression of increasing uses of PSI and to measure hospital safety. And the reason for that is because PSI really helps healthcare workers detect any error and also impede any error, because it allows healthcare workers to see who is diagnosed, what medication goes to which patient, who is being discharged, the claims for each patient, and it really minimizes error to the best extent that the tool can work. However, there is room for improvement, and this article really highlights that with the results of the study. And so one of the reasons to why the study is conducted is to see how does PSI improve with the help of patient feedback. And so how was this study conducted? The study was conducted using feedback from a gathering of 2,471 volunteers. This study was conducted in a six-month time period between May 2013 to September of 2014. 231 patient-reported safety concerns were classified as patient-developed categories. All reports underwent a two-stage clinical review process to identify patient safety incidents, or also referred to as PSI. So how was this done? This table shows the sample demographics of the study, and it's a layout of how the study was conducted. So like I explained, 2,471 patients were recruited. However, only 579 provided patient record incidents. But there were so many patient-reported incidences that those 579 provided a total of 1,155 patient-reported incidences. The way that the study was categorized, it was categorized in 14 sections. They're classified with age, gender, ethnicity, number of patients, days spent there, the wards that they were in. So the ward specialties are surgical specialty as well as medical specialty. So for age, there's a mean of 18 years, a median of 58 years, using an age group within 16 to 91 years. Gender, for females, there was a total of 303 females. For males, there was a total of 272 males. For ethnicity, 547 of the entire 579 were white British, 8 were South Asian, and 21 were of other ethnic origin. The number of inpatient within the previous 5 years was a mean of 3. However, there was a median of 1 patient. So the days spent in the hospital, there was a mean of 7, and there was a median of 4. Like I mentioned before, there was 2 ward specialties, and for the surgical specialty, there was a total of 18 wards, and 390 patients were studied. The study was conducted in this ward. For the medical specialty, there was a total of 15 wards, and 189 patients were studied in this ward. So for sample and design, I'm going to further explain how they broke up the study. So the data was collected between May 2013 to September of 2014, like I previously mentioned. It was conducted in 33 hospital wards total across 3 NHS trustees, which was a total of 5 hospital sites in north of England. They tested the efficiency of PRAISE, which is patient reporting action for a safety environment. So what is PRAISE? The patient reporting and action for safety environment intervention allows for patients to anonymously report safety concerns using a theory-based and evidence-based reporting instrument. So to further explain this, they collected information from inpatients about their safety at 3 points over a 12-month study period. Here they used these data to explore if the patient feedback could support health services to measure and improve the quality and safety of care by addressing the following research questions. The first question is, what concerns about safety do hospital patients report? 2, how do patients make sense of and categorize these safety concerns? 3, what is the incident and nature of the PSIs experienced by the sample of questions? The data reported here were collected using a set of previously validated survey questions for inpatients, 17 administered by research staff at their bedside during hospital stay. Data collected, as I mentioned before, proceeded between May 2013 and September of 2014 as part of a multi-center waitlist-assigned cluster randomized controlled trial conducted in 33 hospital wards across 3 NHS trustees, 5 hospital sites in the north of England. This trial was designed to access efficiency of PRAISE intervention, co-designed with patients and hospital staff. In total, 15 medical wards and 18 surgical wards agreed to host the study across the 3 NHS trustees. So now I'll be moving along procedure. So, again, how did they do all this? How were healthcare workers, researchers prepared to conduct the study? So prior to even collecting data, researchers were given a handbook and scenario training. So they underwent training, which included an outline of the research, an overview of the human factors involved in patient safety, the consent process, how to respond to and record a patient incident report, and how to use a safety netting protocol that a patient should report a serious event that required escalation. They also underwent scenario training and were given an opportunity to familiarize themselves with the measurement tools using the computer software previously developed. All researchers who were new to the project shadowed and were absorbed by the team who developed PRAISE prior to interviewing patients alone. Patients were eligible for participation if they were ages 16 or older, able to give informed consent with a minimum period of 4 hours on the ward. Patients were excluded if they were too ill, if they were too distressed to take part, had already taken part in the study within the previous month, or were non-English or non-Urdu speaking patients. Feedback was elicited at any point within a patient's stay after a minimum of 4 hours on the ward. Patients were classified by demographic information, and these demographic information were age, gender, ethnicity. All of these were self-determined, by the way, by the patient, time of present admissions, and the number of admissions over the previous 5-year period. Participating patients were asked the questions, do you want to tell us something that has concerned you about your care? Where patients did wish to report a concern, responses were directly inputted into a tablet computer by a member of the research team. Using the following prompts. Number 1, please tell us what happened with your concern or experience in as much detail as you can. Number 2, why do you feel this was a safety concern for you? 3, what do you think could be done to stop this from happening again to you or other patients in the future? For this, I am now going to explain the analysis. So as I mentioned before, the data was analyzed in 2 stages. So the data was analyzed in 2 stages. First, stage 1, 2 clinical researchers individually reviewed patient incidences, and there was a total of 1,155 incidences that were reported. The patient volunteers were supported by researchers to develop meaningful categories for patient feedback that reflected the patient's perspective, with all patient incidences reports then sorted into these categories. Second, all patient incidences reports underwent the 2 clinical review process for the identification of PSIs, with incidences of PSIs documented across categories. There was a total of 603 reports that were classified by 3 doctors. These 3 doctors had undergone training. They previously undergone training with 50 report incidences, and they all had different specialties. Their specialties were respiratory specialty, OBGYN, obstetrician and gynecology, and one specialized in geriatrics, which is elderly patients. 533 reports were classified by medical reviewers. So in total, there was a total of 1,115 reports, and they were divided by 2 different groups of people that reviewed them. The stage 2 process was once PSIs were reported once a report incident was reported as PSIs, the reported PSIs were then rated against the standard risk incidents. So the rating was a 4-count rating, a 4-digit rule rating, which the rating for 1 was that it definitely could have been prevented, and for 4, it was definitely not preventable. And then for severity, if for 1, it classified it as being negligent, and for 5, it presented it as catastrophic. I meant to say for 1, it was definitely not preventable, and for 4, it was definitely preventable. So for the incident risk, for the standard risk incidents, there was 4 categories, and for the severity, there was 5. For results. So this is very important in the study. Of the 2,471 patients recruited, 579 patients provided, as I mentioned before, 1,155 patient incident reports. However, not all patient incident reports were classified as PSI. So even though there were only 579 patients provided patient incident reports, more than one patient reported 2 or 3 times. And so 83 patients reported more than one identified safety event, which led up to the total of 1,155 patient incident reports. So, what are the most reported PSIs then? The article responded to this question by first answering the question, what concerns about safety do hospital patterns report? And I'm going to mention again, the patient incident reports were sorted out into 14 categories. So, 251 patient incident reports were of communication among the patients and the staff. 153 patient incident reports were of the staff availability and insufficient staffing. 141 reports of the environment such as noise at night, light levels, ward layout, etc. 135 reports were about issues of compassion, dignity, and privacy. Now, this is further laid out by the tables. The tables give what the patients have complained about and also examples of what these complaints are. So, to explain, the number one complaint that patients had was about communication. And there's 3 different forms of communication. There's staff to patient, staff to staff, and patient to staff. So for staff to patient, patients went for a scan, an x-ray, without any warning of information about why the scan was being done. For staff to staff, one nurse said that they could go home after an x-ray and have possible dressing change. The doctor said that they would go home and have the x-ray as an outpatient and go as they are. For patient to staff, patient was concerned about 5 procedures in case of a fire started. The patient was partially sighted and felt that an emergency he would leave. The side of the bed was up and he felt that he was unable to get out of the bed, and the fire procedures were not explained to him. Now, for staff issues, which was the second most complaint, were that the staff seemed overwhelmed and that things sometimes were not done on time. An example of this was that a patient had a cannula replacement to be done, and instead of it being done at 18, which is a military time, so 18 minus 12 is 6 p.m. Instead, they were awakened at 2 in the morning. And for the sole reason that there was no trained doctor to do it on time. The third most complaint is the environment. So the night staff were noisy, they were talking loudly, shoes made it difficult to fall asleep, they slammed the doors. An example is that the bath is very difficult to access because the side is high, and that patient had to use steps, which was very dangerous because it could be a safety hazard since they could fall. Number 4 was that many patients feel like there was a difficulty of staff expressing compassion, dignity, and privacy, respect. Consultants needed to remember that there is a patient as well as an illness. An example of this is that one night a patient struggled to get out of the bed. The call bed was put out of reach, which made that person unable to contact for help. And the second night call bed was again out of reach, and the patient had to crawl out of bed as the side rails were put up, and the patient got out. The staff were sat around eating takeaway. And for the 5th, it was medication issues. Many patients stated that there were delays in getting anti-sickness tablets following admission. Patients needed them before meals, but on several occasions got them too late. An example was that a patient was almost given anticoagulant twice in the same day, but stopped the nurse and told them that he had already had it. That could be very dangerous. For number 6, many delays because, again, staffing has something to do with it. Many hospital settings are understaffed. It takes a long time for a discharge process to happen. Sometimes it takes up to 8 hours, it has been reported. And for staff training, it's been reported that electrically operated bed. Staff do not know how to use it, and patients know more. An example of this is that another patient in the bay has dementia and has been aggressive towards the staff. He was punching and grabbing the staff, and they were unable to get out his grabs. A senior nurse came and showed the staff what to do in this situation. This is part 2 of the complaints. And some other ranking categories of complaints are food, drink, and nutrition, ward management, equipment and safety failure, infection risk, and repeated procedure complication. For food, drink, and nutrition, patients complained about being unable to eat anything but breakfast for the past few days because the food is unpleasant. For ward management, many patients complained that they went to the nurse desk to ask a question and that they were all gone. They had to sit on chairs for around 30 minutes until a porter took them to a surgical assessment ward. For 10, for equipment and safe systems failure, the night lights were flickering and gave a patient a headache. For 11, infection risks, bedpans were left in the toilet for hours, and the smell of one of them was horrendous. Number 12, health and safety. Patients described a patient in the same bay who was dementia and causes some disruption trying to get in bed with another patient. Sometimes patient woke up and saw her standing over her, and it's quite scary, especially as quite poorly herself. Number 13, for repeated procedure complication, a patient came in 3 weeks ago with abdominal pain, went for a scan, said all fine, and then they sent them home and was still not well. They were sick at home, and then they were readmitted for the same problem, and then it was treated after being admitted for the second time. And for 14, it was not a concern. And for this patient, this was only one patient. The patient was moved from orthopedic ward to surgical ward because out of bed storage. The move was once they got appropriate care for being moved to a non-specialist area. A nurse from the trauma ward did attend to make adjustments in the knee brace. They were not concerned. The patient was involved in decisions to move her. This is to answer the 2 and 3 questions that were presented throughout the study. So the second question was, how do patients make sense of and categorize these studies? All the related safety incidences and examples of these concerns were all provided in the examples and instances that were explained just now on table 2. And so the patients made sense, and each thing was categorized, as I mentioned before, in 14 categories that matched with one of the 14 categories that the patient had a report incident of. For 3, what is the incidence and nature of PSIs experienced by this sample of patients? So 406 of the total 1,155 patient incident reports were classified by clinicians as a PSI. Of the 2,471 patients recruited, 264 reported 1 or more PSIs. This is important because that means that 1 in 10 patients has a reported PSI in a hospital setting. That means that 87 individuals reported more than 1 PSI. This is a range of 2 to 7 reported patient incidents, which is a median of 2 reported patient incidences, or PSIs. Figure 1. Figure 1 is a comparison of patient-derived safety concerns and classified PSIs. So for the first stage of the analysis, 62% of the initial classifications were agreed to not have been considered as PSI. So the first stage of classifying this study was to classify if the patient-reported incidences were PSIs or not. And we see that 62% were not. Those that were classified, however, were further categorized by incident risk factor of preventability. 1 being definitely preventable and 4 being definitely not preventable. And severity, which was 1 minor incident and the other one was catastrophic. And 5 being catastrophic. For Table 3, Table 3 describes the frequency and percentages of classified safety incidences, PSIs, by patient-derived safety category. 54 patient-reported incidences of communications were PSI. 49.2% of patient reports of staff training were PSIs. 42.5% of patient reports of staff issues were PSIs. 25.2% of patient reports of compassion, dignity, and respect were PSI. 22.2% of patient reports of food, drink, and nutrition were PSI. 57% of patient report of environment were PSI. And since there was only 1 volunteer that reported non-concern, there was only 0% of the reported non-concern that was not PSI. For Table 4, Table 4 is an assessment of the severity and preventability of safety incidences and the percentage agreement between the reviewers. So this is the second stage of the classification, which is the second stage assessment after the reported incidences by the patient have been classified as PSI. So the patient's incident reports that were classified as PSI underwent another assessment referred to as incident risk assessment. This assessment measured the severity of patients feeling unsafe and the preventability of reported incidences. So, for negligence, those who reported negligence had a frequency of 186. So 186 PSIs were of negligence, and it was definitely preventable. And then for a minor, it was 44%. It happened 44 times. And it was probably preventable because it happened in a frequency of 47. For major negligence, it was 1 time, so 1 PSI, and that was definitely not preventable. For catastrophic, there was none. And so there was a total of 405 that were reported as negligible, minor, or moderate. And 95% of those classified as probably preventable, definitely preventable, which just shows that there was just a lot of negligence involved in the patient care. That could be for many reasons. So for the discussion, as I mentioned before, 1 in 10 reporting safety concerns meets the clinical definition of PSI. This information is so important with the discussion. So for the current method of safety measurement in hospital settings, there is an underestimated levels of PSI. 17.7% of patients experience a serious harm event in a large observational study. And in this study, 65% of the concerns expressed by patients in the study would have not been classified as PSIs. This is important because this just goes to show how important patient feedback is for the improvement of the usage of the tool of PSI for improving overall patient care. So for the conclusion, patient feedback is important. Gathering information from patients is essential. It is super essential for patient feedback. The reason for that is because gathering patient feedback about safety supports the movement of a safe care and resilience in healthcare services in two ways. First, collecting patients' feedback will allow healthcare organizations to gain a unique insight into the things that are overlooked by error detection methods. Second, with gathering safety concerns systematically, it will allow patients and other families to provide information for service managers to resolve any safety incidences or prevent them quickly. The feedback was limited in data since volunteers were asked about their care. Volunteers all have difficulty defining safety. Many have different definitions of safety. And so it was really challenging to have a study conducted on just the patient feedback, but this study was conducted with just the patient feedback. And so this is why this study is so important, because it had no clinical feedback whatsoever. The only time that clinical staff were used in this trial was to classify the report incidences. And that was just to remove a little bit of bias. However, because there were patients that may not know the categorized classification of safety, the PSI classifications that were only made with patient feedback could either be overestimated or underestimated in the study. But, however, having the knowledge that 65% of the incidences could have not been classified with PSI just alone with receiving patient feedback just goes to show that the findings of the study suggest that the patients can provide important insight about safety that improves healthcare services and eliminates safety incidences that could have not been detected with error detection methods. And so these are the resources that I used to do this entire presentation. Just to further summarize the entire PowerPoint, patient feedback is super important because PSI is a very important tool in healthcare. It is very important because it helps healthcare workers organize the healthcare setting of in charging a patient, how if the patient should wait in the emergency room, if you should let them go. There's so many errors that happen, like as mentioned in one incident, one patient had to be administered twice, and it was only until after the second administration that person was treated for the issue that they came for twice. It helps with finance, it helps with billing, it helps with correct medical billing, it helps with the delivery, it helps with the delivery of care for the patient, making sure the patient is receiving the right care, making sure that every patient is cared for, making sure that the patients are given the right medications, and if they're given the right medications, the right number of times that they're receiving the medication. Like I mentioned before in an incident table 2, it is explained that a patient was going to be given aspirin twice because the nurse was so overworked that they forgot that they already gave it to that patient earlier. And it also helps with the evaluations of patients. As I mentioned before, any complaints that were reported with patient feedback with the tool of PSI, it was quickly reported within the computer or tablet. And these reports really help with the quickness of receiving any type of improvement to anyone who has to deal with the management services of the hospital. So thank you so much for taking the time to read my presentation, to hear from me. Thank you once again. I am crediting SlidesGo and Google Slides for the beauty of this presentation. But however, all the information that has been inputted has come from the resources that are written here in APA, and also from what I have learned with this article. Thank you so much. Bye.